Hello, thank you for joining us today for our program, Health Equity and Communication Strategies for Nurses and Social Workers. I'm Heather Vance, a Master of Public Health intern in the Pharmacy Division at Alabama Department of Public Health. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in and evaluation. While content may continue to be relevant, CE credit will only be awarded for 2 years, expiring on July 1st of 2024. If you're watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it with your sign-in sheet and evaluation. For social workers, if you are watching this program live, it qualifies for classroom hours. If you are watching on demand, it is considered non-classroom hours. I have a lot of information to cover today, so let's go ahead and get started. Hello everyone. Today I'll be discussing health equity and communication strategies for nurses and social workers to help reduce health disparities. Like I said, my name is Heather Vance. I am a Master of Public Health intern in the Pharmacy Division here at the Alabama Department of Public Health. There are no relevant disclosures from any planning or presenting staff to state here today. Today's objectives are to define health equity and distinguish the difference between equality and equity, understand key components of health equity, define health literacy, and describe how communication strategies impact health literacy, and demonstrate how to communicate in a culturally competent manner and assess patient understanding. Before we get started, I would just like to go over a little bit about me and my journey into public health. I'm a Minnesota native who attended the University of Wisconsin-Madison for my undergraduate education. I received a bachelor's degree of science in nutritional sciences, and this is where I had my first exposure to health and food inequities in the United States. Throughout my coursework, I decided to minor in global health. Because of this, I became involved with an organization where I worked hands-on with improving food access and security in the Madison, Wisconsin area. Then, when the COVID-19 pandemic hit, I became involved in public health when I noticed how essential public health is in ensuring the safety of communities and populations. I decided that this was something I wanted to be involved in, and in December of 2020, I was accepted into Auburn University's Doctor of Pharmacy program and enrolled in University of Alabama at Birmingham's Master of Public Health Coordinated Degree program. Now, as of this presentation, I am 1 year into my Doctor of Pharmacy, and I'm finishing up my last courses of my Master of Public Health degree. So now the question becomes, why health equity and communication? To me, the answer is simple: somebody who has years of practice with public health. But to best answer this, we want to discuss health outcomes for our patients and clients and how to address the gaps in knowledge and practice in our fields. Nurses and social workers interact directly with the population, providing education and resources and care. Patient education alone is not enough to achieve major public health goals. When it comes to patients and clients, we need to look at other strategies besides education. This being said, we need to further discuss the importance of health literacy and communication in the nursing and social work fields. Healthcare professionals may not recognize low health literacy or understand the impact on health outcomes. In a 2011 cross-sectional study of health literacy and nursing professionals, more than 80% reported that they never or rarely formally assessed health literacy, and 27% never or rarely asked if a patient had difficulty reading medical information or completing medical forms. In a 2011 report on health literacy opportunities for social work and healthcare, it was identified that health literacy had received very little attention in social work literature. Health social workers work with many patients with low health literacy and are an asset to address these issues. Identifying these gaps in knowledge and practice helps us address health equity issues. Health equity is defined by achievement, when every person can attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. It is important to distinguish the difference between equality and equity. Equality is giving each individual or group of people the same exact resources or opportunities, no matter their background or circumstances. Whereas, on the other hand, equity is understanding that each person has different circumstances and allocates the exact resources and opportunities needed to reach an equal outcome. The focus of equity is the achievement of an equal outcome for everyone, no matter the resources needed. While equality focuses on giving people the same exact resources, equity focuses on the equal outcome. Oftentimes, equality is thought of as fairness, and equity is thought of as justness. In this classic example of equality and equity, the picture on the left demonstrates equality. Both people were given the same length ladder, despite one side of the tree being higher than the other. Now, looking at the image on the right, it is demonstrating equity. The difference in tree height was recognized. For both to have equal outcomes, different size ladders were needed. While this is a very simplified example, it demonstrates the overarching differences between equality and equity. So, what is inequity? Inequity is reflected in differences in length of life, quality of life, rates of disease, disability, and death, severity of disease, and access to treatment. Inequities are the result of disparities in key contributing factors of health equity. Some factors that influence health equity are social position, race, ethnicity, gender, religion, sexual identity, disability, and income. These factors could either improve or inhibit the achievement of equity. The social determinants of health, also known as SDOH, are the conditions in the environments where people are born, live, learn, work, play, and worship. They also refer to the aging and the effect of a wide range of health, functioning, and quality of life outcomes and risks. These play another large role in disparities in the achievement of equity. In this image, you'll see examples of classes of the social determinants of health and the way they impact the individual in the center. These social determinants of health are healthcare access and quality, neighborhood and built environment, social and community context, economic stability, and education access and quality. Both nurses and social workers play different roles in each area of the social determinants of health, but improving one area can also have effects on other areas. In the state of Alabama, there are many considerations for health equity that are important. Alabama ranks 38th in state health system performance, according to the Commonwealth Fund's State Health System Performance Scorecard. Racial health inequities persist among Black, American Indian, Alaskan Natives, Latinx, and Asian residents across the nation. Nationwide, 36% of all counties are at least 25% non-white. In the state of Alabama, 57% of all counties are at least 1/4 non-white, which would be 38 of 67 counties. Life expectancy metrics can vary drastically by geography, but they are very useful in examining how environmental, political, socioeconomic, and structural conditions impact health. In Alabama, the average life expectancy is 75.5 years, which is 3 years less than the United States average life expectancy of 78.5 years. In 66 of Alabama's 67 counties, the average life expectancy is below the United States average, and it is significantly lower in counties with higher proportions of non-white residents. Higher income correlates with lower mortality and better health outcomes. In Alabama, the median annual household income is $48,123, which is 20.2% lower than the United States median annual household income of $60,336. In 63 of Alabama's 67 counties, or 94% of Alabama, the median annual household income is below the United States average. According to the Federal Communications Commission, 10% of United States residents lack access to broadband. This is a trend that the Joint Economic Committee found to be more pervasive across communities of color. Approximately 13.9% of Alabama residents lack broadband access, compared to 6.5% of residents across the United States. In 26 of Alabama's 67 counties, or 38.8% of Alabama, at least half of all county residents lack broadband access. The Health Resource and Service Administration, HRSA, designates geographic regions as health professional shortage areas, or HPSAs, if they lack healthcare providers. Counties in Alabama exhibit an average mental health HPSA score of 16.4 compared to the national average of 15.5. The HPSA score is on a scale of 0 to 25, where 25 denotes an extreme healthcare provider shortage. 82% of Alabama's counties are designated as mental health HPSAs. Now that we have covered health equity in Alabama, we can address how to improve health equity in the state. One way to do that is by understanding an important component of health equity, which is health literacy. Health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information needed to make appropriate health decisions. Health literacy plays a huge role in patients' and clients' decisions on their health and well-being. Furthermore, it is the ability to understand and use health information, allowing patients to make well-informed decisions and incorporate a public health perspective. Health literacy is important because health decisions should be collaborative and allow patient control and advocacy. Common reasons for low health literacy are that healthcare providers use words patients don't understand, there are low education skills, there may be cultural barriers to healthcare, and there may be limited English proficiency. There are many ways to use communication to improve health literacy. The first being using active verbs in plain language so that all members of your audience can understand the information. Another is to recognize that while people may not be literate, they possess other life skills that enable them to lead meaningful lives and contribute positively to society. It is also important to acknowledge that many people with English as a secondary language are highly literate in a non-English language. Similarly, it is important to recognize that people may not be literate in their primary language, and it is important to avoid assuming that people with English as a secondary language will understand written information when it's translated into their primary language. It is also important to consider the lack of digital access and literacy. Some people may not have access to technology, and others may not know how to use it. The National Action Plan to Improve Health Literacy was released in 2010. Its core principles are that all people have the right to health information that helps them make informed decisions, and health services should be delivered in ways that are easy to understand and improve health, longevity, and quality of life. The National Action Plan consists of 7 goals. The first being, develop and disseminate health and safety information that is accurate, accessible, and actionable. An example is providing patients or clients with approved resources that are evidence-based or fact-checked. These materials should also be easy to understand and written with plain language. Goal 2 is to promote changes in the healthcare delivery system that improve information, communication, informed decision-making, and access to health services. An example is advocating for patients or clients to improve health equity within your organization when a disparity is noticed. Goal 3 is focused on childcare and education. Goal 3 is to incorporate accurate and standard-based health and developmentally appropriate health and science information and curricula into childcare and education through the university level. This goal is largely directed to policymakers and researchers. However, as nurses and social workers, it is important to remember that the type of communication, including the language used, varies based on the target audience. This is something we'll discuss further. Goal 4 is to support and expand local efforts to provide adult education, English language instruction, and culturally and linguistically appropriate health information services in the community. An example is to identify patients or clients who lack understanding of materials and communicate with them in a culturally competent manner to meet their understanding. Goal 5 is to build partnerships, develop guidance, and change policies. Public health agencies play a more prominent role because of their population-based approach and their responsibility to promote and protect the health of all. These agencies have a wide range of activities that directly connect to health literacy. For example, they develop and disseminate health information, pay for and deliver healthcare services, collect data on population health issues, and conduct evaluations of interventions and determine their effectiveness. Goal 6 is to increase basic research in the development, implementation, and evaluation of practices and interventions to improve health literacy. Much of the evidence on interventions comes from improving doctor-patient communication, simplifying written materials, and using video or other supplementary materials. More studies are needed to compare more than one intervention. Goal 6 is also targeted for researchers and evaluators, but it's also important for public health professionals such as nurses and social workers. The final goal of the National Action Plan, or Goal 7, is to increase the dissemination and the use of evidence-based health literacy practices and interventions. One way to achieve Goal 7 is to actively engage practitioners, community members, consumers, and policymakers in the research process. To achieve this goal, researchers and evaluators may connect with social workers or nurses throughout their research process with questions related to health literacy practices. Now that we have covered ways to improve health literacy on the large scale, we can also discuss how to improve health literacy at an interpersonal level. Communication is an important interpersonal skill to improve health literacy. Communication strategies are the ways that we communicate with our patients or clients. There are many types of communication strategies, and just a few of these are presentations or training modules like this one today, posters, flyers, brochures, radio or TV advertisements, reports, and verbal communication, among many others. It is important to select the appropriate communication strategy for the patient, client, or population. This selection should be specific to the target audience of your program, intervention, or policy. So it is important to understand who the target audience is and what a target audience is. The target audience is the intended audience of a program, project, or intervention. To better understand the target audience, it is important to collect background information such as education level, language, age, gender, location, and interests. This helps ensure communication is specific to that audience or patient. When it comes to a program, project, or intervention, it is important to clearly state the purposes, goals, or objectives in relation to the target audience. The way in which we communicate and the language we use in communication also plays a large role in health literacy. Culturally and linguistically appropriate services, also known as the CLAS Standards, aim to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred language needs, health literacy, and other communication needs. When communicating with a patient or client or population, it is also important to remember these CLAS standards. A way to follow CLAS standards is by using the Flesch-Kincaid grade level calculator. This determines the ease of reading based on a U.S. grade level scale. It is also known as the readability indicator. Ease of reading impacts health literacy and understanding, because often information is presented with uncommon words that the general public would not know. For the general public, the recommended grade level is 7th or 8th grade. Flesch-Kincaid uses a complex formula to determine reading ease. So often I recommend using a web-based tool that you can just copy and paste your information into. However, if you'd like the calculation, you can also pull up that on Google as well. If you do a simple Google search for Flesch-Kincaid grade level calculator, there will be multiple free options that pop up to use. On these websites, you will simply copy and paste your text and hit calculate. It will generate a readability score for you. Another easy tool to calculate the readability of a document is already included in Microsoft Word. The first step is to open up the document you want to check ease of reading on. Next, once that document is open, on the top left, you'll have to select the File button. This screen should pop up. On the bottom left, you will select Options. The Options dialog box should open. You'll have to select Proofing on the left column, and then you'll look down at the bottom of the right. Under When correcting spelling and grammar in Word, make sure that it has Show Readability Statistics checked. If not, you will check that box and hit OK. It should automatically take you back to your document. And in the bottom left corner, you should see a book widget that kind of looks like an open book with some words on it. You'll click that widget and it'll pop up a screen that has readability statistics. Under readability, you will see the FLESH reading ease and grade level scores. This will give you an idea of what grade level is needed to understand a specific document. It may not be often that you will be creating your own communication to provide to patients, and you'll be using resources that may already be made for you. In those cases, checking the documents you already have for reading ease can help you learn a lot about what language to use or to avoid to help improve health literacy. Another option to use the FLESH Kincaid would be in the Microsoft Word Online form. It also has a readability score integrated into its program. Similarly to the desktop version, you will open your Word document and you'll be able to quickly see the readability statistics without having to change quite a few settings. You'll select the Home tab, choose Editor, and then go to Document Stats. A dialog box will appear letting you know that Word is calculating your document stats. You'll then want to choose OK. Word will open a window that shows you information about the statistics and reading level of your document. Now that we've discussed other ways to communicate, such as flyers, brochures, or posters, we can focus on verbal communication strategies, which is the most common form of communication between nurses and social workers and their clients. Strategies for effective verbal communication are focusing on the issue and not the person. You have to be genuine, empathize, and be flexible. It is also important to value experiences that the patient or client may have already had, and to use affirming responses and plain and clear language. Another way to use verbal communication strategies to reduce health disparities and improve health literacy is through community engagement. This builds trust and relationships between nurses and social workers and their patients or clients and the communities that they work in. Community engagement is a foundational part of the process to develop culturally relevant, unbiased communication for health promotion, research, or policy making. Next up, let's discuss how we gauge patient and client understanding of materials or communication. A great way to do this is through a method called teachback. This video here will demonstrate what teachback is and how we can use it.
What in the world is teachback?
Teachback is a way to confirm what your patient understands of what you've explained. It's a great tool that will not only help reduce our readmissions and improve our patient's experience, it improves our patient's comprehension.
I just don't understand. I don't have time to do teachback, and furthermore, what would I get out of it? Plus, I feel like I would be quizzing my patients and putting them on the spot.
I know. I felt that way too when I first started hearing about teachback, but I started to find phrases that worked for me, and now it feels authentic. I could actually see it help my patients and found that it helps to reduce the calls I receive after I've left the room.
Hey, you two, what are you talking about?
We just had this meeting about teachback.
Teachback? What's that?
Teachback is really a best practice that enables us as providers to learn from the patient what they understood by asking them to repeat back what they heard us say.
Oh, sure. I do that with my patients. As a nurse, I think it's my job to make sure I explain things well, so I'll say, I know we covered a lot of information. Can you tell me what you heard? Or I'll ask them a question like, when you get home, how many times a day are you going to take your medication? and just make up questions to be sure they understand. If they go home and don't understand how or when to take their medications, they could end up back in the hospital, and who wants that?
So do you just use Teach Back at discharge?
It's very useful during discharge, but I also use Teach Back when I'm doing any kind of education, or for sure when I'm sharing a new diagnosis. I've also used it when I see patients in the clinic too. It helps to make sure they know what the plan and the next steps are from the visit.
Yeah, I use it during their visit after I have reviewed the plan of care and what's coming next.
That's interesting.
Morning, Kevin. Have you thought any more about that Teach Back we were talking about?
No, but even if I wanted to incorporate this, I feel funny. It feels forced.
Let's try. Come with me to Mrs. Smith's room. I'm going in to discuss her discharge instructions, and you can see how I try to incorporate Teach Back. Knock, knock. Hi, Mrs. Smith. It's Dr. Gray again. I have Dr. Campbell with me as well. Would it be okay if he joined us today?
Yes, that would be all right with me.
Great, thank you. Well, Mrs. Smith, you're doing much better now, so we're ready to send you home. But it's really important that you make an appointment to see your primary care doctor, Dr. Johnson, within the next 5 days. If your symptoms get worse between now and then, we want you to come back in right away so we can check you out. It's also really important that you take your medication as prescribed, 2 pills 3 times a day with food. Mrs. Smith, I know we've covered a lot, and I want to be sure I explained everything to you clearly. Can you tell me what you're going to do when you get home? When will you go to see Dr. Johnson?
I'm going to contact my doctor if I'm not feeling better in the next 5 days.
I'm sorry, I must not have explained it all very clearly. What I actually want you to do is to call Dr. Johnson, your primary doctor, and make an appointment to see him, regardless of how you're feeling, within the next 5 days.
Oh, I see. You want me to call my doctor even if I'm not feeling bad. I should still plan to follow up with Dr. Johnson in the next 5 days.
Yeah, that's right. You've got it. Now let's see. What questions do you have for me?
I guess that made a difference. She actually didn't understand.
Yeah, sometimes it's the small details that can make a big difference in how the patient does after they've left the hospital. It's always best when we can clarify those details in person before they go home. A few moments of Teach Back in the moment can help ensure patients receive the right follow-up and can save time in the long run. What do you think about Teach Back now?
I think I want to give it a try. I'd hate for my patients to be missing key details in their care. I guess I don't really know what my patients are taking away from my explanations and instructions, and I won't find out unless I ask them.
In summary, Teach Back is a way to check the understanding a patient or client has of the conversation or communication that was provided. It is important to note that this is not a test of the patient's knowledge. Instead, it is a test of how well the concept was explained. It is important to use Teach Back throughout educating or counseling a patient or client, not just at the end of the interaction. By using Teach Back throughout an interaction with a patient or client, you are able to fill in gaps or knowledge sooner and reinforce patient understanding more often. Another example of the Teach Back method is, we covered a lot today, and I want to make sure that I explain things clearly. So let's review what we discussed. Can you please describe the 3 things you agreed to do to help you with control of your diabetes? By doing this, the patient will then demonstrate their understanding of what was discussed. As a provider or practitioner, this allows you to check for those gaps in the understanding. Because you may have thought you explained things clearly and the patient understood them, that might not always be the case. This method is often used by healthcare practitioners, but it is also a great opportunity for social workers to improve health literacy in their day-to-day interactions with patients or clients. That concludes my presentation about health equity and communication strategies. Upon completion of this presentation, we hope that you are able to define health equity and distinguish the difference between equality and equity, understand key components of health equity, define health literacy and describe how communication strategies impact health literacy, demonstrate how to communicate in a culturally competent manner, and assess patient understanding. I would also like to take some time to answer any questions you may have. After this presentation, if you are watching this remotely, you can submit any of the questions that come up or things that you would like clarification on to the contact information for Nancy Bishop. This will be listed at the end of the presentation.
Heather, I have a question. The video on the teach back method was very eye-opening. Could you give us some examples of how you've used that in the pharmacy?
Yeah, I've actually had a lot of practice using the teach back method in the pharmacy. It's often seen sometimes that a patient may just be nodding their head at you versus actually understanding what you're talking about or responding appropriately. For me, for the most part, I look for a lot of nonverbal cues. Things where they look like they're questioning or they're just not really listening. Another thing that I do is then at that moment I take a pause, I try to reassess the situation, and I try to restate what I had said. And oftentimes in the pharmacy, I will provide this big spiel about how this medication may have side effects, or sometimes, most often, it's really expensive and they can't afford to pay for it or pick it up at that time. So I'm walking them through these long, complex stages of how to get it covered or so they can get their medication. Through that process, I'll stop and say, okay, so we've discussed, and then I'll outline those key points. And after that, I will go over and ask them, just to be sure I covered everything, what should you do next? What are your next steps? That also gives the patient a little bit of accountability, and they can also continue to advocate for themselves and to collaborate with you in making their health decisions.
When I was in school, we taught it as don't ask yes and no questions. Ask open-ended questions. And that's, I think, real important because patients tend to just nod yes to anything that you ask. So you are correct in getting them to get some feedback, give you feedback to what they really understand. What has been one of the most challenging communication situations you've been in? And it can be outside the pharmacy if that's appropriate.
Yeah. There's actually been a lot of instances where I've had a hard time communicating with not only patients or clients, but with my peers. I think that being in a healthcare profession, I assume the people around me are equally versed in the things that I'm talking to them about. And that's one thing to refer back to when you're speaking verbally with somebody, is to use plain language and to never assume that they already know what you're talking about. So an example of a time where I thought that I had a hard interaction with somebody where we weren't understanding each other was with, it was in school actually, I was in class, and we were assigned to these teams and these groups, and we're working on this project. And in the project, my partner and I were stating the same thing, but we were saying it in completely different ways that the other person didn't understand. So I think when it comes to applying that to a patient or a client or providing them materials or information, it's important to just use as clear and complete language as you can, and to just take those moments to use the open-ended questions and be like, what I hear you saying is, and then you can see if the way it was interpreted was correctly or not.
Very good. And I would like to challenge all those listening to this program to think about what they can do in their communities to improve health equity. You've had experience in 3 states because you grew up in one state, went to school in another, and now you're in Alabama. So I'm sure there's a lot of difference in what you're seeing through your classwork. Can you provide any insight into what you've seen in Alabama as far as health equity and equality?
Yeah, a lot of the things that I've seen in Alabama are similar to what I've seen in Minnesota and Wisconsin, but to different degrees. So I had seen a lot of food inequity in Wisconsin. A lot of places aren't walkable. There weren't grocery stores. Communities weren't in areas where there was public transportation. Now coming to Alabama, studying the public health program, looking at the same issues, I've noticed that in places like Birmingham, communities that were low income, reliant on the public transportation system to help them get around, have been moved out of the low income and affordable neighborhoods that were on those transportation lines and pushed further out to where they have to walk further to get to a grocery store. They have to walk further to get to public transportation. Similar things like that, but to a much larger degree in Alabama than they were in Wisconsin. Another really great example of something that is different here in Alabama than what I'm used to at home is the interstate system. At home in Minnesota and Wisconsin, the interstates and the highways run through all of the small towns, and each town you'll be going 70 and then you'll slow down to 35 just because you're going through all of those towns and all of those people will have access. In Alabama, it's very different. You're going on the interstate or the highway the whole way, and those smaller communities don't have the infrastructure, the roads, the transportation to get to the larger areas where there's hospitals, where there's grocery stores. So that's another example of things I've noticed that are different.
We certainly have enjoyed having you here as an intern this summer. I feel like one thing we do need to look at in the pharmacy division is to look at our patient insert documents that the patients receive on their medications, and using the tools that you have shown us, we could evaluate those to see what grade level they are. Do you have any advice into how to tackle that project?
Yeah, that's a large project. All those package inserts and the patient information, that is a lot of stuff to go over. But I think that using something similar to Flesch-Kincaid grade level calculator would be super helpful, especially because a lot of those documents are already in Word docs, so you can just assess them there. The part that is difficult is you can check the reading score, you can see how easy it is to read, but it's changing that language into plain and clear language. So the best place to start is kind of creating that word bank of substitutions for complex words that would be used in those package inserts. So instead of using this long word that has a lot of syllables, you could use something similar as a synonym that's shorter, easier to understand, more common. The biggest issue, I would say, or the biggest thing to overcome with that is finding the right words to use to still say the same things. But doing something is better than nothing, because a lot of patients will open that package insert, look at it, not understand the first 5 words, and decide that that's not something they'll be finishing reading.
We all at the pharmacy, we're all challenged with time. It's usually very, very busy. So how much time do you think talking to the average patient would take if in this communication mode or method that you're using?
I think that right now healthcare is in a place where time with a patient is not a first priority. And even if it's not in a pharmacy setting, if you're in the doctor's office or as a social worker speaking with your client, I would say it only takes a couple of minutes. It only takes a couple of minutes to check in and say, what do you understand about whatever the topic is? And honestly, a couple minutes a day for a lot of patients may add up to a lot, but those patients that you're able to help, those 2 minutes that you take and say, what do you understand? What can you tell me about will really end up helping their health outcomes in the long term.
I know drug interactions can really play a part in communication with a patient, and a lot of times for elderly people it's very difficult to get them to understand how drug interactions can impact their health. Do you have any advice for us when we're dealing with the elderly on drug interactions?
Yeah, I think one thing to really consider with the elderly population, talking about drug interactions or just speaking to them about complex health issues in general, is that they've went through a lot of changes. And there's a lot of things that have changed from the time they were born to what they're experiencing now. And to be able to tell them their drug interactions, to be able to say that to them might be really confusing, as you had said. So the best way to do that is to go one by one. It's a step process. I always say take it a little bite at a time, but so things might seem a little overwhelming to them if you were just to sit there and list out all of their medications, everything that they can have with them and everything that they can't have, or things that aren't working well with it. That'll be a lot for them. So I just would say just one bite at a time. Start with, okay, here's the medication that you're on. This is what it's interacting. What do you understand about that? Or just to be sure I covered it correctly, what can you tell me about the way these two medications interact, or this interacts with your food, or something like that. Yeah.
Any other words of wisdom for our nurses and social workers in the clinic? I know you've had the opportunity to see a clinic and visit how public health works. So do you have any words of wisdom for us?
Yeah, my biggest words of wisdom or advice to social workers or nurses is that it's best to not assume that the patient knows what's going on, and it's best to just explain everything, no matter the patient, as fully and clearly as you can, and really just checking with the patient and empathizing with them and letting them know, because a lot of the patients seen in the community health clinics that are part of the public health division are people who aren't able to afford health care, or people who are going through testing for any STIs or anything like that. So it's really important to be empathetic and to not pass judgment and to build that relationship with them, because you want them to be comfortable and come back and have a good experience with healthcare, because a lot of people miss that experience.
And I would say that starts from the first time they walk in the clinic.
Yes.
From the front door to as they exit.
Yep.
How has your time here at Public Health changed the way you view public health?
When I first started here at the Alabama Department of Public Health, I didn't know what I was getting into. I think is the best way to say it. I've read about public health departments, I've read the research, I've used the data, but I've never actually been on the ground and seen what's really going on behind the doors. I think that some of the most impactful things that I've learned that I'll use in the future is that public health is everywhere. It touches everything. Even if people think that public health is really just the posters and the billboards, it's so much more than that. It's in everything. It's the systems that we use to communicate. It's how we receive our services, whether it's online. The services could be subsidized, such as WIC or things like that. And I think the biggest lesson to me is that everything that I see for a community that could possibly be beneficial is public health. So it's important that it's not just one thing, it's multifaceted, it's collaborative. And that's my biggest takeaway from my time here.
Well, we have really enjoyed having you this summer, and I know that you're starting your second year of pharmacy school, which you will get through this. Second year's the toughest. But I think you've also opened eyes of the pharmacy division and what we could do as to support the county health department clinics in patient care. And I'm excited to use some of these communication methods that you have discussed and try to have an impact on getting patients to feel comfortable coming to the clinic and receiving care from us. I guess just to wrap up, maybe you could give us some insight into what you see as your future and how you plan to incorporate public health into it.
Yeah, that's a great question. I've been asked that question a lot. Why pharmacy and why public health? And I think that a lot of people think of pharmacists as the people who are in your communities in the retail environment at a Walgreens, a CVS, or a similar place that just fill the prescriptions and hand them out to you. As a pharmacist, you're the most accessible healthcare provider in the United States. There's one within miles of almost every city or town, and that is honestly why I went into public health. I'm from a rural community that didn't have good healthcare systems. It didn't have the people needed to support them, and the patients coming into our community pharmacy where I worked were really struggling with getting answers to their questions, and we're struggling with the way the system works. So as my future in pharmacy and public health, I'm not sure where it's going to take me. I'm really hoping to be in a position where I'm able to help patients get the services they need. I want to be able to refer them to a social worker if they tell me they're having food insecurity or they need help finding other services. I want to connect them to the correct nursing staff if they need immunizations I can't provide. I'm not sure if that'll be in a community pharmacy. I'm not sure if I'll be in a hospital, but public health education that I've received so far has really made me want to change the way the healthcare system works. It's a slow process, but I believe that if you start patient by patient and you work one by one moving through, then you're going to make a large impact at the end.
Well, we look forward to seeing how you succeed at that. We know you'll do great things for the healthcare community.
Thank you.
Thanks so much for this presentation, and we appreciate your willing to share your knowledge with us.
Yes, I appreciate being here today and being able to provide this presentation about health equity communication strategies. I also just want to do a final reminder that in order to receive that credit for this training, you'll need to complete the evaluation form, and you have to watch the entire program, and then the sign-in sheet and evaluation form need to be returned once those are finished. Final thing is Nancy Bishop was my preceptor, so she'll be the point of contact for you if there's any questions that come up. She'll send those on to me, and I'll answer them to the best of my ability. She's the state pharmacy director here at the Alabama Department of Public Health. I also just want to take a couple of minutes to say thank you. I'm really appreciative that I had this opportunity to present, to let you guys know about what I've learned about public health and how I have hopefully been able to provide it and apply it to other people. And I want everybody to know about how important public health is and the way we communicate with people, how important that is on impacting health outcomes. So thank you.